Good afternoon to everybody attending the final webinar in our Experts on Air series on closed loop ventilation. As I'm sure most of you know by now, my name is Caroline Brown from Hamilton Medical, and I have the great pleasure of welcoming our two experts, Dr. Giovanni Sbrana and Professor Giorgio Iotti, both from Italy. Today, they'll take to the skies and show that INTELLiVENT-ASV, which is relatively new on the Hamilton T1 ventilator, can help at the patient's side even during emergency air rescue. In case there's anyone in the audience attending for the first time today, your cameras and microphones are switched off, but you can ask as many questions as you like using the Q&A function. The session is being recorded, and we'll send out a link to the recording by email early next week. And with that, it's time for me to hand over to our very experienced interviewer, Giorgio Iotti. Giorgio, it's over to you. Thank you.
Thank you, Caroline, for the introduction. Today, it is my pleasure to introduce our speaker, Giovanni Sbrana, medical doctor, PhD, anesthesiologist, who after several years of activity in intensive care is presently director at the emergency medical system of Arezzo in Tuscany. But what's more important for today's speech, he is medical doctor at the helicopter medical system of Grosseto, also in Tuscany. The topic is from the bedside to the clouds, or maybe from the clouds to the bedside, arriving to the bedside. So please, Giovanni, we are ready.
Thank you. Thank you, Giorgio. Thank you to everybody. Thank you, Caroline. And thank you to all the people connected today. It's for me an honor to be here today, and I'm very pleased to speak with you about these interesting topics.
And Giovanni, as our tradition, we start with a question, a poll to the participants, and two questions actually. The first one is ventilation type during transport. So what type of ventilation would you choose for an intubated patient during transport, assuming that the necessary equipment is available? So just manual ventilation, conventional ventilation with conventional machine, or partial automation, let's say something like ASV, or high automation, so something like INTELLiVENT. Please, we are open for checking your answers. Okay, so winning is partial automation. That's very interesting, but some participants are open even for high automation. Very well. And the second question is more medical. So which is your primary target during transportation? So focusing more on effective ventilation, achieving effective ventilation, or just good oxygenation, or protecting the lungs, protecting the brains, or all these targets? Okay, all of the above is the most common preferred choice, but it's interesting, effective ventilation. So to be sure that the patient is ventilating is in second place. Thank you very much to the participants. And now, please, Giovanni, go ahead.
Thank you, Giorgio. And these are my conflict of interest. I was saying, let me introduce my Grosseto HEM space. It's we work with the AW139, is phase 7, so the more modern AW139. We work 22 hours a day for all year long, 22 because for 2 hours a day the helicopter is in maintenance in the morning and in the evening. We work, we fly aided with NVG, and we do special operation just during the daylight time. But we work with the night vision goggles during the night. We perform about 1,000, 1,200 missions per year with a 6-people crew. We are short notice to move during the day. During the night, we are airborne in 20 minutes. Meantime, the majority of our mission are primary rescue mission on the site of the accident, and we fly with 2 pilots, 1 specialist, an helicopter hoist operator, and 1 emergency physician or intensivist, 1 registered nurse, and during the day we also have 1 mountain rescue operator. We carry blood on board. We hear a lot of discussion about the mission of HEMS all over the world, in Europe in particular. We perform primarily pre-hospital stabilization and primary transport. We also perform a good quote of inter-hospital transport of critical care time-dependent patient, but it's not our first mission, it's not our first competence and effort. We also perform search and rescue. We have a hostile environment, and so we perform sometimes a search and rescue mission, and sometimes we have major accident mission engaged. About the equipment, you know, there's no strong agreement about the equipment on the helicopters. We follow the Italian Association of HEMS Bases indication that splits the equipment in mandatory, very useful, nice to have. About the mandatory equipment, I have to say ventilators and defibrillators are mandatory, definitely mandatory. I think everywhere you do not perform HEMS mission without a defibrillator and a ventilator. We also have a very useful equipment such the ultrasound is recently becoming very, very useful. And also we have some nice to have equipment like the point of care blood gas analysis that could be interesting in some mission, particularly using the blood. Of course, the equipment keeps space, work as a payload, so reduce the capability of the helicopter to carry patient or the autonomy of the flight. And so you have to choose what you need, what you want to use. For example, we have the mechanical chest compression because we perform a lot of ACLS mission, but we know it's a big equipment and is also weighty. Monitoring is not therapy, we know, and sometimes we have to face with monitoring because performing, for example, blood gas examination during the flight, we know we reduce the situational awareness of the team. Here you can see a video, a short video about this, and you can see how the team is busy performing the blood examination. So sometimes information are important, so you choose to compromise and to do the blood examination, but sometimes it reduces your situational awareness. Not always technology increase the situational awareness, and we know looking at the street and the car accident. The cognitive load is important during primary HEMS mission. We know we have to take care of ventilation. We have to take care of oxygen delivery and neuroprotection. We have to take care about non-invasive or sometimes invasive blood pressure, perfusion of tissue perfusion, ECG, end-tidal CO2, patient. Sometimes our patients are speaking. Relatives, sometimes we carry relatives, for example, for pediatrics patient. We have to take care of the crew because sometimes pilots need to work in a stressful environment, instrumental meteorological conditions and so on. We have to take care of the medical crew, the nurse, and also the rescuers, the mountain rescuer that is with us. Stress and fatigue. Okay, stress is something that belongs to us. We are human. We know we perform a lot of mission, particularly during the summer with the hot weather, and so we know stress and fatigue is not the same to start at 8:30 and perform a rescue mission than to do it at 5:30 after a complete day flying and seeing patient. Is not the same. About the equipment, the interaction between the therapies is very important. So we know that ventilators is something in the middle, connecting circulation, breathing, and metabolism of the patient. It regards all of this. And so we have to keep ventilation adequate because it's an important therapy. Sometimes is the main therapy we can provide to our patient, to our critical patient during the transport. So the question, the clinical issue, can I have the same quality of care as in the ICU? Can I carry the ICU close to the patient? And does it matter? We think it matters. Sometimes it matters more, for example, with brain trauma patients, sometimes less, but you cannot transport a critical patient and rescue a critical patient forgetting what you learn in the intensive care, what you learn in the emergency department. So you have to carry quality, and you have to carry the same expertise and sometimes the same kind of equipment. So I want to show, to close, a couple of clinical reports case. This is a trauma, a young male that underwent a couple of years ago to a motorcycle accident with helmets, was found unconscious, shocked, far from the, you can see on the picture, far from the motorcycle. The impact was about 10 meters before the place where we find him. And as you can see, in a very rural area, isolated from all the hospital and rescue, very, very far from the major trauma center. An ambulance was arrived before than us, a few minutes before us, and the patient presented with the traumatic brain injury, abdomen trauma, limb trauma, and chest trauma. What we did on the scene, we stopped the bleed. The ambulance had already applied a tourniquet. We applied a pelvic binder. We perform orotracheal intubation and ventilation, of course, with drugs. We perform an ultrasound that was positive for blood. We perform therapy with the blood and fibrinogen and tranexamic acid. Then the patient was airborne to the major trauma center. It takes about 25-30 minutes to fly to the major trauma center from the site of the accident. During the flying, we had a crisis. During the flight, we had the sudden desaturation hypotension. Of course, we performed the bilateral finger thoracostomy. And we had to transfuse one more unit of blood, O negative blood, to the patient. And we had also an air leak from the chest. We had a crisis in the ventilation, and later the CT scan showed a bronchial lesion. We managed this patient with the INTELLiVENT-ASV, and I have to say that we were very, very happy to return to the nature of the INTELLiVENT-ASV, because INTELLiVENT, again, gives you the chance to decide the strategic decision to set up the ventilation in the correct way. You are intensivist, we are intensivist, so we know as we have to do it, but go on in tactical decision during the crisis. And that gives a lot of chance of focusing on the crisis. In this case, focusing on the chest trauma and the air leak and pneumothorax. The second case is something less crisis. I would say is a more quiet patient. Is a 65-year-old female that had a cardiac arrest with VF as a presentation rhythm, and had a ROSC after 20 minutes. A short no-flow time, less than 3 minutes, because the the cardiac arrest was witnessed by citizens, and so they other people bystanders started the CPR, and we also had a low flow time because the ground ALS with the mechanical chest compression device arrived in 15 minutes. They put an extraglottic device and manually ventilated the patient. We arrived on the scene after 25 minutes, so 5 minutes after repristinum of spontaneous circulation. What we did, the patient was in coma with no respiratory drive, in cardiogenic shock. We performed drug-assisted intubation, ketamine and fentanyl and rocuronium. We performed a fluid challenge, obtained a 12-lead ECG that showed occlusive myocardial infarction, administered aspirin and heparin IV, and airborne the patient to the cath lab. It takes about 30 minutes. So my question to you is, does this patient deserve a particular management? Is this really a relaxing patient, or there's some therapy we have to provide during the flight? Do you think we can stress on airing up to the cath lab? Do you think we have also to allow good perfusion, neuroprotection, lung protection? What do you think about this patient? I would like to discuss with you later about this. So thank you very much, and want to leave space to the discussion, and I'm of course available for you.
Thank you, Giovanni. Thank you for your for the general presentation and for the two very interesting cases. So coming to the last questions that you made. Well, what is your answer? What is your answer? Because, well, reaching as soon as possible the cath lab is, of course, is a must. But in the meanwhile, the patients should reach the cath lab with as little damages as possible.
Yeah. You have to leave cardiologist space to work on this patient, and also intensivist.
So they do their job, but
our job is still going on. I think that of course she has to hurry up to the cath lab, and this is probably pilot's job. Of course. It's a joke. It's the job of all the team, but we have to focus on stabilization of this patient, because I am sure that all of us has to recognize that this is a neuro lesion patient. So she deserves neuroprotection. She deserves good oxygenation. She deserves good perfusion, because she has a cardiogenic shock, and we have to help her heart to do its job, her sick heart. And so we have to let the ventilator do good job to achieve all these targets. And ventilation is therapy, and is the more important therapy we can provide to this patient during the transport.
On the other hand, both the two examples that you have shown, it's clear that ventilation is a very important part. We like it very much, but it is just one part that takes time, takes energies. And so they are probably technology.
It's a part you have to join with the other part of the therapy, but it's a very important part And also when the crisis look overwhelmed, looks as everything it's okay now, we have just to run. No, ventilation is playing an important part. And you have to set the ventilation close to the needing of the patient, close to what you would do in the intensive care.
Which is very ambitious. Is very ambitious on the field and in an helicopter to approach the same levels as in the much easier context of the intensive care. By the way, we have some questions. So the first question is, okay, you in this example, you used the top that was available, and probably this helped you to focus on hemodynamics, on transfusing the patient, making the thoracostomy. But normally, question is normally, which is your default ventilation mode?
We normally start in ASV.
So not all cases are so critical. Yeah. Not all cases are complex. Yeah. Sometimes the transport is shorter. Yeah.
Even we have an average time of transport of 25-26 minutes, so it's not so short, and I'm sure you can do several damages to the patient in such a time. And anyway, sometimes we already discussed it together. Sometimes we do not understand how many damage bed transport can do. Nobody of us could tolerate 5 minutes of bed ventilation in an intensive care, and transport is never a 5 minutes transport, neither for the CT scan from the intensive care. There's no 5 minutes. So usually what we do, what's our strategy is, we start in ASV and we look what ASV does. We try to stay in a quite safe but not too high FiO2, so usually 40% if it's possible for the patient.
Okay.
And not too much PEEP. Okay, we give PEEP, but not too much. After a few minutes, usually the time needed to load the patient and close the door and say, okay, we're ready to take off, we switch to INTELLiVENT. Okay. If it's possible. It depends on the patient, it depends. But if it's possible, we encourage colleagues to switch to ISV.
So now coming to the second question that is linked by Annalisa M, that is linked to this one. So the question was, do you use INTELLiVENT in all your patients? Yes and no, not necessarily. ASV, yes.
Yeah.
ASV, yes.
ASV, yes. ASV, definitely yes. Not all in INTELLiVENT, but we try to do our best to use INTELLiVENT the more responsible.
And the question is partly the other way around. So if not, in which patient you would not even try to use INTELLiVENT?
For example, we do not use INTELLiVENT sometimes if we transfer a long time intensive care patient, because sometimes we say, okay, it has been ventilated for a week in an intensive care.
So secondary transport.
Secondary non-time dependent transport, because our policy is an secondary interhospital transport of a strictly time-dependent patient. It's something like a primary mission, because he's losing a chance. Sometimes we move patient, for example, during the COVID period, we moved patient after a long time, not so urgent. So sometimes we decide not to use, but
Perfect.
The majority of our patients are INTELLiVENT after a few minutes.
So we have two more interesting questions from anonymous also about using INTELLiVENT. So do you have sometimes issues with the pulse oximeter probe?
We had in the first period, now we are going better. Of course, we always look at the PI, we always look at the pulsatility index, because a very low perfused patient, of course, cannot provide good data.
But Giovanni, no specific problem, the helicopter?
No.
So the reading, the probe?
No. We know.
So the issue may be in the patient.
In the patient.
Perfusion, cold.
Of course, cold patient, of course, are problems, and we know. We use a warming machine. We use the MECU fluid warming machine to provide warm fluids to hypothermic patients. But we know that a severe hypothermic patient cannot provide good data. But not for the helicopter. Neither we had problems with the end-tidal CO2. That I have to tell you that using INTELLiVENT has been a stimulus for everybody to look more at the end-tidal CO2. Look more and understand more volumetric end-tidal CO2.
We have also an interesting question from our friend Jesse Van from the Netherlands. Jesse says, you mentioned an air leakage, bronchial lesion, so how much leakage would you consider tolerable for applying ASV and INTELLiVENT?
I have to tell you that it's difficult.
Officially, the large leakage is from the company is a contraindication. No?
Yeah, but I have to tell you, this patient had not huge leakage, and the patient, I have to tell you, was very well ventilated by the ventilators. Of course, a leak requires operators focus on the leakage, but the INTELLiVENT gives you the chance to focus on what is important. You don't have to stress on FiO2 or what else. You have to focus on the patient and not on the single details. Nobody of us now should fly on an helicopter with no autopilot. The pilots fly with the autopilot, and I have to tell you that my pilots are very, very good pilots, but they fly with the autopilot. When it's needed, they use the autopilot.
From Giovanni, one short question. Did it ever happen that you had to switch off INTELLiVENT and let's say downgrade your approach?
We sometimes downgrade stopping the control of the oxygen when the patient is too cold to provide good data on the SpO2. Not to stop INTELLiVENT, but we reduce the contribution of it because if the data are not
to manual oxygen.
Yeah, we usually try to have the blood gas analysis if we have time with the point of care in order to understand what data we are reading. But if the patient is too cold, you got no plethysmography, and so you cannot use it.
Giovanni, another question is, what about your colleagues? Is it just you who are so fond of this technology, and how long did it take to your colleagues to get confident and to use?
I believe in medicine. You always can split doctors and also nurses in 3 categories. You have the early adopter, like me, the enthusiastic, the pioneer. You have the people that immediately follows the news after the pioneer, colonizer, I would say. And we have the reluctant, the one that say, no, at my time we do with
go ahead.
Manual ventilators, manual also, manual is always the best. Of course, we are lucky. We are lucky because we have a small staff, a small, very experienced staff. So we just, now we have a problem with doctors because we are not unable to find new doctors. Anyway, our average number of doctors rotating on the helicopter is 8, 10 doctors. So we work as a small intensive care staff. And also nurses are small number, 12, 15, no more. So we use a lot the ventilator, we fly a lot, we work a lot together. We have time to discuss patient about once a month. That is a very good chance to share experience and use the experience with the others. I can understand that it's a small staff, so we work too much, and it's true. But this gives you high quality and helps you also in all the new technology and all the new techniques. For example, blood on board or so on.
And from Jost Begus, who also says greetings from Slovenia. He has asking, do you generally have good experience with the ASV on COPD patients in these emergency conditions?
COPD patients are not our primary case mix because trauma, stroke, and cardiac arrest are our primary case mix of patients. Anyway, we sometimes had to transfer the COPD patient and
as secondary
mission. Yes, we did it with such a good. Again, if it is a time-dependent secondary transfer, for example, a patient that goes for a myocardial infarction, but is also intubated and is also COPD. It's different than a COPD patient recovered in a small ICU since 2 weeks, and we move him to a higher hospital. The new patient, the recently intubated patient during the flight, takes more advantage of INTELLiVENT, according to me.
Giovanni, so now there is a classic question, important. So do you think that with INTELLiVENT in use, doctors, intensivists might forget how to ventilate, how to perform good ventilation?
I think exactly the opposite. I think it is the chance to better understand ventilation. If we have time, Giorgio, I would like to compare with something of the usual life. Most of us in Italy were driving with manual gear. Now we are trying to understand the automatic gear. We are trying to use the automatic control of the speed, the automatic, the assistance of the guide, and so on. And you need a driving license, and you need to be experienced driver to drive. But technology helps you in doing better and reducing the cognitive load and reducing mistakes. I think it's the same with technology in ventilation. You get stimulated by INTELLiVENT, more stimulated to understand ventilation, stimulated to understand policy and technology of the ventilator. And so I think you study more because of INTELLiVENT.
So you are reassuring for that. Well, since we are close to the end, now a question that is a little bit a chance for repeating some concepts, reviewing some concepts that you tried to transmit. So what is the primary reason for starting to use INTELLiVENT in this condition, transport?
Definitely reduce cognitive load and reduce allow doctors to focus on the patient, not on setting a new FiO2 or a new PIP every 3 minutes or 4 minutes. Speaking only about FiO2, we know that new guidelines say no more than 94–95% SpO2 in a neuro lesion or in a ROSC patient or so on. And this is very important. And if you are flying and you have no time, you don't focus on the patient because of looking at the FiO2 and change FiO2 every 3 or 4 minutes. It's stupid.
No,
Machine can do it for us.
I think you brought a good, very important example, because these new indications for a restricted range of oxygenation, so no hyperoxia, but also absolutely no hypoxemia, is difficult. Is difficult to achieve, and for sure it would be very difficult during transport without a strong technological.
Before INTELLiVENT, Giorgio, we arrive in the hospital with 200 millimeters of mercury
because it's
of PaO2.
The concept is that better high than
low. And this is,
thank you very much.
A huge mistake.
Thank you very much, Giovanni.
Thank you,
very
Giorgio.
much to the attendants, and we hope that they have been interested by this a little bit different expert on air. Caroline, please.
Thank you, Giorgio. That's a wrap for today, everybody. We'd like to thank you all for being part of this series, and we hope you found the webinars informative and also useful. And of course, as always, a huge thanks to all our experts in this series for all the valuable information they've shared with us. Our next Experts on Air series will start in autumn. So if you're not already subscribed, you can sign up for our Academy newsletter, which also has all the event news, to receive information about the next series in a few months' time. And as always, may we ask that you answer the few short questions that appear on your screen when you leave this session. So thank you very much. Bye for now. And to everyone in the Northern Hemisphere, we hope you have a lovely summer vacation. Thank you very much, and bye for now.
Thank you to everybody.
Thank you to everybody, and bye-bye.
Bye-bye.